Module 5, Comfort and Sensory Perception. So we all know what our five senses are. We have taste, touch, sight, smell, and hearing. And all of these senses work together to help us interpret and interact with our environment in a meaningful way. So in order for us to grow, develop, and function, we all must be able to sense and respond to sensory input. Okay, so these five senses provide information about our external environment and also our internal environment. And it also helps our body to maintain homeostasis. One important thing to remember is that any patient that does have a sensory impairment is that the Joint Commission requires that we address the communication needs of these patients, whether it's related to vision, speech, hearing, language, or cognition. We have to make sure our care is patient-centered and that we address each individual need. There are several components to our sensory experience, and we're going to start with stimulus. So our senses give us information about the environment inside and outside of our bodies, and the whole purpose of sensation is to allow the body to respond to changing situations and to maintain homeostasis. A sensory experience involves different components in the nervous system, including a stimulus, reception, perception, and an arousal mechanism. So here we have stimulus. This is any kind of trigger that stimulates a receptor. It can be music, it can be smell, it can be touch, it can be pain. But not only does this work by itself, it has to have the brain to be able to process that message and interpret it so it has meaning to us. Next, we have reception. So reception is a process of receiving stimuli from nerve endings in the skin and inside the body. A receptor converts a stimulus to a nerve impulse and transmits it along sensory neurons in our central nervous system, our CNS. So some receptors remain activated for as long as the stimulus is applied, but most receptors adapt to the stimuli. So that means that their response declines with time. This adaptation explains why over time you become unaware about an unpleasant smell or the persistent hum of an air conditioner, for example. If you look at this picture here, you can see different types of receptors under the skin. So thermoreceptors are in the skin and they detect variations in temperature. Then we have proprioceptors that are in the skin but are also in muscles, tendons, ligaments, and joint capsules. And they coordinate input to let us know the position our body is in space. Then we have photoreceptors. These are actually located in the retina of our eyes and they detect visible light. So again, reception is the process of receiving stimuli from nerve endings. And those nerve endings will send the impulse up to the sensory neurons in our central nervous system, and that is where our brain will interpret this data. The next component of the sensory experience is perception. So perception occurs when the person becomes aware of the stimulus and receives the information. One thing to note is that it's not possible for all the stimuli that is constantly around us to be interpreted by the brain. So our brain discards about 99% of all sensory information and considers it irrelevant and unimportant. So perception is the ability to interpret sensory impulses. It gives us meaning to the impulses, and it's affected by the location of the receptor, the number of receptors activated, the frequency of action potentials, and any changes in those above things I just mentioned. And lastly, we have arousal. So the reticular activating system, or RAS, located in the brainstem, controls consciousness and alertness. So the neurons of the RAS make connections between spinal cord, cerebellum, thalamus, and the cerebral cortex, and it relays visual, auditory, and other stimuli that help us to stay awake, attentive, and observant. So without this type of stimuli, the CNS becomes lethargic and the person may lose consciousness. So some things that can affect this is anesthesia, sedatives, opioids, and other drugs that depress this RAS or RAS system, as does a darkened, quiet environment. So this, as a nurse, you should be thinking, okay, if a patient is in a room that's dark and quiet for long periods of time, then this RAS system that controls our arousal may become lethargic, and it may make the patient, be really, really sleepy, drowsy, unattentive, and lose consciousness. So how do we respond to these sensations? So some factors that affect response would be intensity of stimulus. So an intense stimulus excites more receptors, leading to a greater response. An example of this would be shining a bright light, a glaring light that will cause you to respond by squinting or maybe covering your eyes, where if you were in a dim light, if you had exposed to a dim light, then you may not have any reaction. Then there is contrasting stimuli. This is being able to sense varying stimuli, for example, hot or cold. So example would be if you're outside and the weather is really cold and windy, but then you enter a garage and you instantly feel warmer. Even though that garage doesn't have a heat or anything, it just, that mild temperature variation, you're able to sense that. Next is adaptation to stimuli, and this is just getting used to the stimuli around you. So for example, if you take the public bus every day and you're walking to the bus stop and you're waiting and there's a construction site behind you that's making all kinds of loud noises, maybe the first or second time that you're exposed to that, it's, you're really annoyed, it kind of scares you, really loud sounds all of a sudden, but then every week or every day you're going to that same bus stop, you get used to those sounds and you almost like they're no longer there, you don't hear them anymore, so you adapt to that stimuli. An example of you as a nurse, we have lots of lights and sounds activity that goes on in the hospital setting. So over time, you become desensitized to those sounds, which can lead to a problem because if you're desensitized to alarms that are, trying to tell you something to go check a patient, your brain may just discard that as unimportant. How this sensory sensation applies to patients is that when patients come and they're admitted to the hospital, those same activities, the sounds, the lights can cause a lot of stimulation, and it can cause stimulation overload. So those kind of things can keep patients awake and give the patients anxiety, and we're going to talk about that a little more in depth as we go on. Next on the list is previous experience. So this is when you've had a prior experience with a stimulus and it's going to affect your ongoing responses to that same stimulus. So for example, if a patient gets an injection every morning and maybe the first time they received it, it was quite painful. After that, every time it's time for that injection, they may tense up, they may look away, they may not want it, they'll grimace. So they're not necessarily feeling that stimulus yet, but they have a reaction based on a negative experience in the past. So in order for anyone to have a response to a sensation, you have to be alert. Okay, so you have to be alert and you have to be receptive to that stimulation. So if you're not alert, if you are unconscious, then some of these sensations there will be no reaction to. So for example, if you're sedated, if you are in surgery, you are being cut open, your insides are exposed, you're not feeling that, you're not having any type of response to that. So continuing on. So now we're going to consider factors that affect our sensory function, our 5 senses. So one thing is lifespan variations. So for example, newborns. When a baby is born, noises might startle them very easily. They may be consoled by touch, by coddling, whereas they grow older, they become more accustomed to certain sounds, so they may not get startled as easily. They may start touching things and tasting things more because that is the stage that they're in their lifespan. And then as older adults, certain sensory organs, pretty much everything in our body, starts to decline, and that is a normal part of aging. So for example, this chart here shows sensory function changes with aging. With our vision, a lot of different structures in the eye due to age. So these are things that we expect. Okay, so if a patient came in and said, you know, my eyes are really dry and it makes them irritated. Well, if they're 75, you know, they may not have a true condition. It could just be normal signs of aging. And then hearing, we talked a little bit about this in class. Cerumen becomes drier, can become compacted, and just that can block sound waves from coming in the ear. So that could also be considered affecting a sensory function. And then you can just read the rest here: taste, smell, touch, a little blurb about each one. Other factors include culture, so this will affect the nature, type, and amount of interaction and stimulation that people feel comfortable with. So if you have a patient that is crying because maybe they lost a loved one, or maybe they just found out that they have 6 months to live, or maybe they're just stressed out, sometimes it is in our nature to maybe sit next to the patient, you know, hold their hand, maybe put your arm over their shoulder, try to console them. But this may not be appropriate for everyone. We all have our personal space and what we're comfortable with. Certain cultures don't touch each other. They don't welcome touch, especially from a stranger. So that's not something that you should do automatically. You kind of have to get to know your patient, and if you don't know, then don't do it. Illness can also affect sensory function. So if you have a problem with the brain or the central nervous system, then you may have an issue with some of your senses, because that's the road that those messages need to go on in order for your brain to get that message. Diseases that affect circulation. So our skin has all of those receptors in it, and if the skin isn't getting blood that has oxygen and nutrients, then things start to decline. So cells will start to die, nerves won't function appropriately. So anything that has circulation, that affects circulation, could affect their sensory perception. An example of this for you is if you've ever slept wrong, maybe on or sat on your foot, like on a chair, and then when you get up, your foot's asleep. You cut off blood supply and now you feel those tingling pins and needles. That is sensory dysfunction. Some other conditions that have specific effects to certain organs are diabetic retinopathy, hypertension, sickle cell disease, and toxoplasmosis. You don't need to know what those conditions are in detail, but just know that there are conditions that affect specific sensory organs. And of course, if you have some type of physiological injury to the brain, like an injury, a stroke, something like that. Medications can affect sensory function. So some side effects of medications could be a foul aftertaste or metallic taste. So that's taste. Some medications that cross the blood-borne barrier affect our neurological or sensory function by damaging or even killing brain cells. If we are sedated in surgery and or anything that causes sedation, even sleeping medication at night, that is affecting our sensory function. Stress, including illness, pain, just being in the hospital, surgery, those are all stresses that can cause sensory overload, too much stimulus, you know, around us. And then we have our personality and lifestyle. So those patients are at risk for sensory alterations if their previous level of stimuli does not match their current level. So say you have a patient that is very active in their normal life. So they get up at 5 in the morning, they have some coffee, they go for a jog, they come back, very active, and then they get sick and they're in the hospital. And all of a sudden, they're in the bed for most of the day. It's just not their routine. They're not used to this environment. Then it can have the opposite effect. They just don't have enough stimuli. Okay, so their previous level does not match their current level. So we're going to talk about two sensory alterations. We're going to talk about deprivation first, and this is something that you will see a lot in the hospital. And many times you may overlook this because you're really busy, and it may not be the first thing in your mind, but it's definitely something that you should consider. So this is when the person does not receive and process meaningful sensory input. So sensory deprivation is a state of the RAS, the RAS depression, caused by a lack of meaningful stimuli. So when the environment is deficient, when there's not enough stimuli in the environment, the remaining stimuli like distant noises, minor pain, cold extremities, they can become overly noticeable or distorted. So for example, let's talk about that patient that got admitted to the hospital and they're at the end of the hall, it's very quiet there. They're pretty stable otherwise, so the nurse isn't checking on them that regularly. Their window shade is always closed, their light in the room is always off. So that is sensory deprivation. After days and days of that way, your brain kind of doesn't have enough stimulus to remember, it needs to trigger our state of arousal. So other stimuli like minor pain, keyword minor, and cold extremities will become exponentially more sensitized. So a minor pain could feel really, really severe just because there's no other stimuli to kind of even it out. It's kind of a strange thing, but it is a thing. So you want to remember and take that into consideration with these type of patients you feel may be at risk of sensory deprivation. Some risk factors of sensory deprivation would be patients who are bedbound or homebound, patients in the ICU, and hospitalized patients that are in isolation. Isolation means that they have some infectious disease and you need to wear PPE to go in. So typically these patients, we cluster their care as nurses. We don't want to keep coming in and out of the room, exposing ourselves and possibly exposing other patients. So you only go in when you need to, and sometimes the door is shut. So that is why patients in isolation are at risk for sensory deprivation. So some triggers could be a nerve or brain injury, restricted mobility, quiet monotonous environment, meaning it's just really quiet and there's nothing going on. Inability to interpret language, social cues, and interactions. So maybe you have a patient that does not speak one word of English and there is no family at the bedside, they're just there. So everything they see and hear, it doesn't make sense to them. They can't read body language, so that can also put them at a sensory deprivation. And then one other trigger is advanced age. So that's important because a lot of our patients are advanced age, so you need to know in your mind they're already at risk of sensory deprivation. How do we know this is happening? So they may become depressed, withdrawn, they could even experience delirium, poor patient compliance, confusion, and even ICU psychosis. So these are all real and significant complications. So sensory deprivation is a real thing and it's something that you need to be aware of. Then we have the opposite. So this is sensory overload. This is when stimuli like pain, unfamiliar sights, sounds, odor, and routines overwhelm the patient's senses. Some example of these things would be alarms, interruptions in rest and sleep by nurses, CNA, and other providers, medical therapies and procedures, the patient care routines. We have to come in, we offer oral care. Do you need to go to the bathroom? They're watching, these people walk by, they hear the sounds out at the nurse's station and in the halls, and even their own pain can cause sensory overload. So some triggers of this could be, in addition to what I just mentioned, neurological or psychiatric disorders, like if they're already anxious, this could cause even more anxiety. Lack of privacy, that can cause you to have a sensory overload if your curtain is always open and you see all these people walking by, or if you have to get up to go to the bathroom and the curtain's open, your mind just starts getting anxious. That can also cause overload. Unfamiliar healthcare environment and patient care routines, I just mentioned that. Okay, so how do we know this is happening? So these patients tend to become irritable, anxious, restless, and even confused, reduced attention span. So they're just bombarded with all of these noises and sounds and routines that they just can't concentrate. They can't understand what you're saying. Drowsiness due to insomnia. So they're up all night listening to these things, being awakened to take vital signs every 2, 3, 4 hours, whatever it is, so that they're sleepy during the day. They have decreased ability to perform tasks, inability to concentrate and focus. They can become disorientated and confused, and distractibility. So again, there are a lot of different types of patients that could be at risk for this. Pretty much every patient that comes in is at risk for overload because it's a new environment, a new place. And it is, again, your responsibility to recognize this and to do the best you can to decrease that stimulation. Ways that you can decrease the stimulation would be to maybe close the patient's door at night, cluster care so that you're only interrupting them maybe 1 to 2 times a night. Ask them, what is your daily routine? How can I help you get your rest? Or, explain what those alarms are, or maybe turn down an alarm, stuff like that. Then we have sensory deficits. This can come from impaired reception, perception, or both. And most common that we're going to see as nurses is going to be impaired vision and hearing. If a patient has a sudden onset of a deficit, it may lead to disorientation and anxiety, so keep that in mind. However, when a patient has gradual changes of some type of sensory deficit, maybe they're losing their sight, maybe they're losing their hearing, people tend to adapt without even realizing it. So maybe you do have hearing loss of some level. Well, we have 2 ears, so maybe the other ear is going to kind of accommodate for it. And you get used to maybe turning your head a certain way so your good ear can hear. So you may not even realize that you're doing that. Then we have compensation. So this is when there's a deficit in one sense, and then the other senses will become sharper to compensate. So if you are going blind and then you can no longer see, your hearing actually becomes more acute. And then vice versa, if you lose your hearing, then your sight may become more tuned to verbal cues, reading lips. You may observe things that you didn't really notice before. So that goes the same with all of our 5 senses. So our cognition, so we need a healthy brain to interpret these messages that are coming to us. So we want to always provide health promotion in that area. And this includes physical activity. This also includes keeping your mind busy, looking for opportunities to learn, remember, solve problems like puzzles, games, engage in personal and social relationships and activities. So maintaining that social interaction, healthy diet, reduce risk factors, especially those that affect circulation, like diabetes, hypertension, and tobacco. Don't take medication that alters your mind, like sedatives, if possible. Sometimes we can't avoid that because it's part of their care plan. Patients should get adequate sleep because sleep is a time that our body uses to kind of recover and reset the day. And then, of course, avoid heavy alcohol consumption because that can alter your mind. So now we're going to talk about how we care for patients that are confused. So confusion interferes with the ability to interpret stimuli accurately. So let's think about this. We now know what a stimulus is. It can be anything related to our 5 senses. So these patients who are confused are not able to interpret those sensations correctly. So we're going to talk about delirium and dementia. So delirium is acute, which means it typically has a sudden onset, and it's usually reversible. So this is often caused by certain medication side effects and physiological processes. So it could be hypoxia, metabolic issues, infections, or a known sensory alteration. For example, older adults that are healthy otherwise may become delirious from one day to the next. And this is usually related to an infection. Most commonly you'll hear about would be like a UTI, urinary tract infection. You have, somebody who's living at an assisted living or skilled nursing facility who's usually alert oriented, and then all of a sudden they become restless and confused and delirious. Very commonly we're going to get a urine culture, blood test, and sure enough they have a UTI. So that's just one example. So again, this can be accompanied by that confusion, that delirium, restlessness, illusions, incoherence of thought and speech, so you can't understand, and change in level of consciousness. So they may become lethargic, difficult to arouse. Then we have dementia. Dementia is not the same as delirium. Dementia is a chronic and progressive deterioration in cognitive functioning. So this is something wrong in the brain, physical changes in the brain. It is not associated with changing levels of consciousness. If you become lethargic, you don't have dementia automatically. So these people will have problems with thinking, remembering, learning, and reasoning. They're going to have changes in their language skills, visual perception, and personality with dementia, and this happens over time. Dementia is not a normal part of aging, so do not use the words delirium and dementia interchangeably. They are very different. So now that we understand what confusion is, let's talk about things that we can do as nurses to care for these patients. So you want to reorient these patients frequently. Ask what their name is, tell them who they are, tell them what day it is, what time it is. You want to provide clocks and calendars so that they can keep track of the days, especially when you're in the hospital for a while. It's difficult to know, is it daytime, is it nighttime, is it Monday, is it Friday? But if we can provide visual cues, then that will help them kind of stay in the present. We want to maintain a safe environment because remember, these patients may not recognize where they are, and if we can make things easy, simple, that will help with their safety. We want to communicate clearly and slowly. We don't want to overwhelm them. Respond to their feelings, listen, use gestures to explain, what you're trying to say. Limit choices. You don't want to give them 10 choices and have them pick one. That can be overwhelming, sensory overload. Promote feelings of security because oftentimes if you're confused, you're scared. So if you can provide security, safety, then that will put them at ease, maybe less anxiety. And recognize that a patient that is confused may have poor decision making. Again, safety is key. These patients require more frequent rounding to check in on them. Keep the door open. You may need to put them closer to the nursing station. Make sure that call light is within reach. They may benefit from a bed or chair alarm that alarms when they're trying to get up. Now we have patients with altered level of consciousness. So these are patients who are not 100% aroused. So that means they're very, very lethargic, or they may not even be responsive. Maybe they're unconscious. So that is altered level of consciousness. So things we can do for these patients. Now remember, you're going to be the primary source of all care for them, which means we need to attend to all body systems. So we still want to continue to orient to reality. If they're conscious, even if they're lethargic, tell them what day it is, morning or night, ask them what their name is, tell them where they are. Safety measures, we want to make sure that the bed is in the lowest position, at least 2 to 3 side rails are up. Remember that 4 side rails up requires a doctor's order because that's considered a restraint. We want to provide eye care, oral care, and since patients with altered level of consciousness have decreased mobility, we want to make sure that we are doing our interventions to prevent pressure injuries. So turning every 2 hours for sure. Range of motion to make sure those joints don't stiffen up because of their lack of mobility. Good skin and mouth care. Urinary drainage. So if these patients have an altered level of consciousness, they're probably going to be incontinent of urine. So there are things that we can do to help mitigate that. For example, a PureWick or a condom cath. Those are external urinary collection devices. Or just to make sure the chuck pad is there and that you are checking on the patient frequently to make sure that they're not sitting in wet linen. Bowel management, same thing. You want to clean that patient as soon as they have a bowel movement. And nutrition. If these patients are not able to eat by mouth, then we want to make sure that they're getting maybe tube feeding or even IV nutrition, which we'll talk about in a later chapter. Next is seizures. So seizures, we're not going to really talk about the conditions that cause seizures. Right now, we're just going to focus on your responsibility as a nurse on caring for a patient that has a seizure. So when you think of seizure, think safety. Okay, safety, safety, safety. Seizures can happen at any time. Sometimes a patient may experience like an aura right before the seizure, or sometimes they've never had a seizure and it just happens. So we have to be aware of all those things. So there are going to be motor symptoms. So jerking of the limbs. There's going to be a decreased level or a complete loss of consciousness. And for each patient, the symptom and duration of the seizure will vary, and it really just depends on the patient and what part of the brain is being affected. So some seizures are short, 30 seconds, a couple minutes. But if a seizure is prolonged, where it's like 5-6 minutes, or if breathing stops, of course, then that is going to be considered a medical emergency and intervention will be required. So different types of seizures, generalized seizure, focal seizure, and recurrent seizures, which is usually the patient will be diagnosed with epilepsy. There are lots of causes. There can be something going on with the brain because, again, this is related to our central nervous system. There could be brain tumor. Maybe you had an injury in the brain in the past. Stroke can cause this sometimes. Hypoglycemia, so low blood sugar, medication. So there's lots of things that can cause seizures. Seizures can have triggers. So, for example, sleep deprivation. If a person has history of seizures and they haven't slept in 2 days, then that itself might trigger it. Stress, illness, alcohol, so lots of different things, and it sometimes varies from person to person. So again, we're focusing on your responsibility before, during, and after a seizure. Okay, so patients at risk for seizures before a seizure happens. So this example is if you already know the patient has history and you are preparing the room. So you want to make sure you have seizure precautions, padded side rails. Make sure that all 4 side rails are up, bed is in lowest position. We want suction at the bedside because we don't want the patient to aspirate. We want to make sure that patient is close to the nurse's station so we could do frequent rounding. If the patient has family at the bedside, we also want to educate them on what to do. We want them to push the call light to call for help so that we can come to the room. And depending on the facility, they may also want you to place an airway at the bedside for emergencies. During a seizure, we want to provide privacy because humans are curious, and if a patient is seizing, sometimes draws a crowd outside the door. You want to stay with the patient. Really important you stay with the patient. If you're not able to call for help or use a call light to call for help, you still don't leave, you stay with the patient. You want to turn the patient to the side, again, so that they don't aspirate. You don't want to put anything in the mouth. You want to loosen the clothing if it's tight. Maybe if their hospital gown is tied really tight and it's kind of getting, stuck around their neck or something like that, then you want to undo it. Make sure there's nothing around them that they can get hurt on. You never restrain a patient who is having seizures because you can actually cause more injury to the patient. If the seizure is prolonged, then you may need to apply oxygen or give some medication, but for this class, you don't need to worry about that part. This patient would be considered unstable, so this is not a patient that you would want to delegate to your LVN. After the seizure is passed, you're going to want to keep the patient on the side and make sure you suction if they have anything in their mouth. When they come to, they are typically very tired and sleepy. They may not remember having the seizure. So you want to reorient them, make them comfortable. You may need to change their gown. They may have had a bowel movement, or they may have urinated, so you want to make sure that they're clean. You don't want to give them anything to drink or eat until they're completely fully awake. You want to assess their vitals and mental status about every 15 minutes or so for about 2 hours. And then you want to make sure you document the seizure. So you want to document what time it started, how long it lasted, when it ended, and everything that you saw. What movements did you see? Was it the arms, the legs, top, bottom, stuff like that. Okay, so now we're going to talk about pain. Okay, so what is pain? Everyone has experienced some type of pain in their lifetime, and we include physical pain along with emotional pain as being the same because it's a type of pain. And I'm just going to write over this bullet here because that is an error. So whatever a person describes their pain as, that's what we take it as. So if they say it's 10 out of 10, it is 10 out of 10. So pain can have destructive effects, of course, which is bad, which we're going to talk about. And then pain can also be beneficial because it's telling us about an injury. It's warning us about something that's going on with the body. It's a multi-dimensional experience because there are so many different factors and dynamics that come along with pain. So pain is the most common reason people seek medical care in the United States, which is pretty interesting. That means there's a lot of people in pain. The pain experience can significantly interfere with a patient's quality of life, or just a person's quality of life, and it really does affect every aspect of life. So can you imagine you have some body part that's in pain, severely in pain every day, you don't get any relief. This type of thing can cause issues with you at work. Maybe you don't want to go out with friends or family. It can affect sexual intimacy, sleep and rest, your ability to exercise, or even just perform your normal daily activities. Pain can also cause irritability, cognitive impairment, functional impairment, immobility. Pain can be destructive to the patient and their family. So those are just a few reasons why we really have to take pain seriously and treat it effectively. One way we classify pain is by origin. So this is where the pain is coming from. First here we have cutaneous or superficial. So this type of pain arises in the skin or subcutaneous tissue. So if you've ever touched a hot object or maybe got a paper cut, that is superficial pain. But although the pain is superficial, it could cause, significant pain, but it's usually short term. Then we have deep somatic pain. So this type of pain comes from ligaments, tendons, nerves, blood vessels, and bones. So deep somatic pain is more localized and is usually described as achy or tender. So a fracture or sprain, arthritis, bone cancer can cause deep somatic pain. Next is visceral pain. So visceral pain is caused by the stimulation of deep internal pain receptors. Most often you'll feel that in the abdominal cavity, cranium, or thorax. So visceral pain is not well localized and it's usually described as tight pressure or crampy pain. For example, menstrual cramps, labor pain, GI infections, some bowel disorders, and organ cancers all produce visceral pain. Then we have radiating or referred pain. So this type of pain starts at the origin, but then it goes out and extends to other locations. For example, the pain of a severe sore throat may start extending or radiating or refer to the ears and head. Okay, so it starts in one place, but then you start feeling it somewhere else. Phantom pain is perceived to originate from an area that has been surgically removed. So for example, amputation, a patient who had a limb amputated may still perceive that limb is still there and will experience burning, itching, and deep pain in that area. Then we have psychogenic pain. So psychogenic pain is believed to arise from the mind, from the brain. The patient perceives the pain despite the fact that there's no physical cause that we can identify anyway. So we treat psychogenic pain just as any other pain because the patient is feeling that pain. So we also classify pain by the cause, duration, and description. So by cause, nociceptive pain. Nociceptive pain occurs when the receptors, which they call nociceptors, respond to stimuli that are potentially damaging. For example, noxious thermal, like really hot, really cold, chemical or mechanical stimuli. So this is when tissue is being affected. Okay, so nociceptive is tissue, injury to tissue that causes pain. Then we have neuropathic. So neuropathic comes from damage to the nerves. So if you have a nerve injury, and that can come from lots of different reasons, like a stroke or uncontrolled diabetes, a tumor, and so on, those type of conditions can cause neuropathic pain. Then we have by duration, so we have acute and chronic. So acute pain has a short duration and is usually has a sudden onset, and it can vary in intensity, meaning it can be really painful and then go down to just mild pain, and it can last up to 6 months. So this type of pain is usually associated with surgery or some type of injury. Then we have chronic. So chronic pain lasts 6 months or longer. Okay, so this one's 6 months or longer chronic pain. And chronic pain usually interferes with patients' daily activities with their ADLs. It can also come with periods of remission exacerbation. But unlike acute pain, chronic pain is usually viewed or often viewed as insignificant because it's really difficult to manage sometimes, and it leads to withdrawal, depression, anger, frustration, and dependence on certain medications. And finally, we also classify pain by the description. So you are aware of this because you guys practice PQRST of pain. So what is the physiology of pain? We're not going to go into this too deeply. You can just kind of read through this and follow along on this picture. So there's transduction, transmission, pain reception, and pain modulation. So please just go over that in your textbook. There are a lot of factors that influence pain. These are just some of them. So emotions like fear, frustration, anger, helplessness, loneliness can all affect the way somebody perceives pain. Past experience with pain, for example, if you go to the dentist and every time you go to the dentist you have severe pain despite what they do, then you may feel more anxious even before the dentist has even seen you. So that previous experience causes you to get anxiety before experiencing pain, and you're actually more sensitive to the pain when they actually start doing something. Developmental stage. So the way people respond to pain is also influenced by your developmental stage. So for example, a baby would cry when they're in pain, or maybe as an adult you may also cry, or maybe you'll ignore it. So it really just depends on what stage in life you are, and everybody's different. Then we have sociocultural factors. So in some cultures, or some people just believe that there's value of minimizing the way you express pain. So for example, if you're in a lot of pain, maybe in your culture, if you express that pain, then maybe you aren't as strong as the next person. Sometimes you can see this when a woman gives birth. So maybe in their culture, they're not supposed to make any sounds, so you really have to hold that inside. So that is another example. Some people may also gain comfort from crying or moaning when they're in pain, maybe just like rocking and moaning, and that makes them feel better. Whereas some people are just in silence and they just are, endure the pain without any sound. So everybody's different, and a lot of times it's based on culture. Communication. So communication and cognition. So some older adults may be unable to report the pain because of cognitive impairment. So maybe they are in pain and discomfort, but they're just not verbalizing it. So sometimes and often their discomfort is only evident in nonverbal cues like grimacing, maybe rapid blinking or labored breathing, altered gait, decreased activity. And patients with dementia may not appear to be experiencing pain, but it doesn't mean that they have any less pain. So again, cognitively impaired adults are not less sensitive to pain, but they just may fail to interpret sensations as painful. So again, remember, patients who are confused, their ability to interpret their senses is altered. So they may be in pain, but their brain isn't really telling them, hey, say something, because it is not good. Okay, so nonetheless, everyone can experience pain even if they're not able to verbalize it. Okay, so next is a scenario. I'm not going to discuss this. I'm going to move on. Okay, so this next slide is an important one. This is the body's reaction to pain. So if you have a patient that is in pain, these are the type of things that you need to think about, because there is a huge impact on every body system pretty much, from unrelieved pain. So starting with the endocrine system. So if you have ongoing pain, this triggers lots of hormones to be released into the bloodstream. And these hormone shifts activate carbohydrate, protein, and fat catabolism, which is breakdown, hyperglycemia, and poor glucose use. Okay, so these are all negative. The inflammatory process combined with these endocrine and metabolic changes can result in weight loss, tachycardia, which is high heart rate, fever, increased respiratory rate, and even death. So again, unrelieved pain for a long time can cause these changes in the endocrine system, and we haven't even moved on to the other body systems, but just the endocrine system can cause all of those things. Now let's talk about the cardiovascular system. Unrelieved pain leads to hypercoagulation, which is increased clotting of the blood, increased heart rate, blood pressure, increased cardiac workload, and oxygen demand. Okay, this is all just from unrelieved pain. Next is the musculoskeletal system. So unrelieved pain in this area causes impaired muscle function, fatigue, and immobility. So poorly controlled pain can even prevent the patient from, performing their activities of daily living and engaging in physical therapy. The respiratory system. Patients that tend to be in pain breathe much more shallowly, so this limits the thoracic and abdominal movement. This is called splinting. So splinting reduces tidal volume, which is the amount of air that comes in and goes out with each breath, and this can lead to pneumonia, atelectasis, and underventilation, which is retaining too much carbon dioxide, and this will lead to respiratory acidosis. Next is the genitourinary system. Again, we're talking about just being in pain for a long time can have this effect on our body. So for the genitourinary system, unrelieved pain can cause excessive amounts of catecholamines, aldosterone, ADH, cortisol, angiotensin II, and prostaglandins. So these hormones tend to lead to decreased urinary output, urinary retention, fluid overload, hypokalemia, which is low potassium, hypertension, which is high blood pressure, and increased cardiac output. Again, all bad things. And finally, our gastrointestinal system. So in response to pain, intestinal secretions and smooth muscle tone increase and gastric emptying and motility decrease. So that combination is not good. So again, if somebody is in pain and it's prolonged pain, unrelieved pain, it can affect the body from head to toe. And here we have on this slide, there is a chart from your textbook, Physiological Involuntary Responses to Pain. So we have our sympathetic responses, parasympathetic, our behavioral responses, and our psychological responses. So being in pain is not a good thing. That's why it's important that you as a nurse, we're assessing our patients, asking them if that whatever you did as an intervention, whether it's pain meds or non-pharmacological methods, are working. We don't want patients to suffer. We don't want them to feel intense pain all the time. And not just because that's what they perceive, but because look at all the things that it does to our body. And one more thing to add to that previous slide. If you already have a sick patient, a patient that's in the hospital for an illness, acute illness, chronic illness, and you already know how our immune system works, we need resources, we need our white blood cell soldiers to be at their best, to help fight off disease and to keep the body healthy. If a patient is in pain at the same time, the body is going to be working overtime. So that's another reason why we need to keep our patients comfortable. Okay, so now we're moving on to the assessment of pain. So assessing our patients include a comprehensive pain assessment that includes pain, location, quality, intensity, aggravating and alleviating factors, time, duration. Okay, our PQRST, you guys are familiar with that, but also what the goals of pain relief are. So when you go into the hospital and you look at the whiteboard, there's usually something there that talks about pain. And there's a pain scale, but there's also an area for you to write what the patient's goal is of pain. So that's really important because sometimes we're never going to reach 0 out of 10 despite what we do. Some people who have chronic pain will never reach a 0, and they're okay with that. They just want decreased pain. So maybe they'll be happy at a 3, at a 4, even sometimes at a 5 because their normal pain every day is so intense. On the other hand, there are times where we can get a 0 and maybe that patient's tolerance is very, very low. So yes, their goal would be a 0. So at the start of your shift, as part of your assessment, when you're asking about pain, after you ask all of those PQRST questions, you want to ask the patient, what is your pain goal? At what level will you be okay, comfortable with? Because we want it to be a goal that's attainable and that's realistic. So if they came in with a 10 out of 10 pain, and they'll be happy with 4 out of 10, then that's what our goal is going to be, because they're more likely to reach that goal than a 0 out of 10. Okay, but the goal is not something that you set as the nurse, it's what the patient says. If they're unable to tell you what the goal is, then we aim for 0. Okay, if they're nonverbal, then we aim for 0 out of 10. Okay, we're also going to talk about nonverbal signs of pain, and that includes elevated heart rate, elevated blood pressure, crying, moaning, rocking, grimacing. Okay, all really important things that you should be assessing when you're looking at your patient. So you should be assessing pain just as often as you would be checking your patient's vital signs, even more so if the patient has pain medication given, okay, because you want to check the effectiveness of that pain medication. Again, make sure you assess your patient appropriately. So that leads us to our next slide. So in order to assess our patient appropriately, we have pain scales, and there are lots of different types of pain scales. The one that we use, or you're more familiar with, will probably be the numeric rating scale, which is like a 0 out of 10. Then we have the Wong-Baker faces, where patients can look at the faces. This works well with children because they just look to see which face they can relate to, and it corresponds to a number. For this, I want you to refer back to your textbook just to read a little bit about each type of pain scale and which type of patient would be appropriate to use that. So the takeaway from this is that you can assess pain on every patient, every type of patient. So you should never say that you're not able to assess pain. Even if the patient is unconscious, nonverbal, sedated, there is a pain scale for that type of patient. Maybe the patient has cerebral palsy, Down syndrome, and their cognition, they're nonverbal, they're not able to express to you, and maybe they don't have any of those. Maybe they're not crying, maybe they're not moaning, but they have other indicators that they may be in pain. So we use a pain scale. These are standardized tools that keep things consistent between providers so that we can measure and then treat the pain appropriately. For example, there's also that's another type of pain scale that's not listed here. It's called the NBPS. That's Adult Nonverbal Pain Scale. If you take a look at that in your textbook, there are different categories. So you look at the patient's face, their activity, is there an expression? Are they restless? Are they guarding? Are their muscles really stiff? How are their vital signs? And how are they breathing? So those are the different categories, and this is just an example. So we talked about how pain affects those body systems. So we can use that as part of our nonverbal assessment to see if those body systems are affected, then we can kind of deduce that yes, they do have pain. Okay, so really important that you're assessing the pain correctly. You're using a standardized tool, you're assessing your patient's body systems, and that you're treating the pain appropriately. So a little bit more about nonverbal signs of pain. So we're looking at facial expression, posture, body position. You want to pay attention to all those physical signs and symptoms. You'll see the sympathetic nervous system responses to pain if the pain is acute. Okay, when assessing for nonverbal signs, you want to make sure that you understand the different facial expressions, posture, and body positions so that you can pick up on those cues. So those are pretty reliable indicators of the intensity of pain. So basic and common facial expressions that signal pain are lowering the eyebrows, wincing, clenching, closing the eyelids, guarding a painful sight, and maintaining like a tense position. Those are all signs of pain. So those are all nonverbal signs of pain. Then we have changes in vital signs. So changes in vital signs are not 100% reliable for every patient that is in pain, okay? I'm going to say it again. You cannot always rely on vital sign changes for assessing pain. If you have acute pain and you're in a lot of pain all of a sudden, yes, your vital signs will most likely change. However, after about an hour or so of being in that pain, your body is trying to take care of you. It's trying to handle things on its own. So it's going to try to find an equilibrium, a balance. So your vital signs may come back to normal and return to baseline, but the patient is still in pain. So you have to take that into consideration. Continuous severe pain may elevate the vital signs again from time to time, it just depends, but they won't stay elevated. They won't remain elevated. So just also take that into consideration. Then we have behavioral manifestations. So patients may not act like they're in pain or what we perceive to be acting like in pain. So patients might use distraction. Maybe they're watching TV or something like that, or maybe even try to go to sleep just to cope with their pain. Those patients are often overlooked and undertreated. Okay, so maybe the patient is laughing with a family member or friend, but that is just their coping mechanism to deal with the pain. So those patients still need to be taken seriously. We still ask them, what's your pain level? And that pain level is what we go by. And we have to believe them. If a patient speaks a different language, of course, we want to make sure we get an interpreter because we don't want that to be a barrier to effective pain management. Some patients, we also need to understand that they feel bad or they may feel, quote, weak if they express their pain. So you'll often see this in, men who are older, or maybe they have a family, all different kinds of scenarios, but they feel like if they don't complain of pain, they're stronger for it. They're not supposed to express pain. So we have to also take that into consideration and build a trusting relationship with them, convey your concern and your knowledge of the person's pain. And this will often have allow the patient to kind of open up to you, trust you, and then verbalize, exactly what they're feeling. And then you also want to remember to assess for depression because depression is also a component that can come along with pain and it's often overlooked, and that can contribute to more pain or prolonged pain. Now we're into pain management, and as you see, we always start with the non-pharmacological pain measures. Why is that? Well, remember that pain medication or any kind of medication that we ingest is going to have side effects on the body. Whether we see them or not, there always is some type of side effect. Also, everything that we ingest has to be metabolized by an organ. So if a patient's already sick with a chronic illness, they're in the hospital, it's just giving their organs more work to do to metabolize that medication. So if a patient doesn't have to take medication, great, okay, or less medication, great. So we start with the non-pharmacological measures. So first off is cutaneous stimulation. So transcutaneous electrical nerve stimulations is a TENS unit. This would be handled by physical therapy in the hospital. It is a little device with batteries, and it's worn close to where the pain originates. And once you turn it on or once it's activated, it starts stimulating little sensory fibers, and that can relieve the pain in that area. Then there's also a percutaneous electrical nerve stimulation device, or PENS, and this combines the same TENS unit, but it is placed through the skin with a little needle, and it stimulates periphery sensory nerves. So it's actually a short-term treatment, very similar idea of the TENS unit. There's also spinal cord stimulator, or SCS, and when you have like chronic neurological pain, this can be helpful for those type of patients. It interferes with the message, the pain message. And then we have acupuncture, acupressure, massage, use of heat and cold. These are all, you can read about those in your textbook. These are all different methods you can offer to the patient if appropriate. Okay, more so for us is going to be, let's see, the use of heat and cold and massage. That's something that we can do. So just a little bit about heat and cold. So local effects of heat and cold. When you put heat on an area of the body, it's going to increase circulation. And we want to alternate. So you don't want to keep it on hot all day. If you apply heat to one place of the body, one area for more than 1 hour, the body will actually start to do the opposite of increased circulation. It's going to decrease the blood flow. That's why we don't want to keep heat on continuously. So it's better to remove and reapply because that heat will restore vasodilation, which is what we want. Continuous exposure to the heat will start damaging cells, and then you'll have, an injury, which we don't want. So heat is good to increase circulation, but not continuous. Then we have cold. So when you put a cold pack, it will initially decrease swelling and pain. But then, just like the heat, if you have it there for a long time, it's going to result in reflex vasodilation. And that is going to eventually lead to reddened appearance and ischemia of the skin, which is not good. So again, for heat, we increase circulation. So if you have a big ankle that has edema and swelling, you're not going to apply heat because that's going to increase circulation. That's going to draw more fluid to that area. Instead, you're going to apply cold because when you put it on, that's going to decrease swelling, it's going to decrease pain. But you don't want to keep the heat there or the cold there continuously. You want to alternate. Now, not alternate heat and cold per se, but remove the cold and then put the cold back on later, and vice versa. Some other non-pharmacological measures would be oral sucrose. So this is used in newborns when they're going to have like mild to moderate pain, like with a procedure. So these babies are given some liquid on their tongue, and that's supposed to be effective to help with the pain. However, this is kind of controversial. Some research has shown that it's not as effective as we think it is. However, it's still used in most hospitals, but they are moving away from that in some hospitals. So just be mindful of that. Then we have immobilization. So you should be familiar with this because this is part of our RICE intervention. So when you immobilize a painful body part, like with a splint, it can offer some pain relief, and this is particularly helpful with patients with arthritic joints. So like in the fingers and the wrist, patients with arthritis there, if you apply a splint, it can help with pain relief. Then we have cognitive behavioral interventions. This is like distraction. So this is a pretty good method of kind of pulling the patient's attention away from the pain and focusing on something else other than the pain. So for example, turning on the TV, offering music, or maybe they can draw or read or something like that. And this kind of plays on the fact that we know that the brain can only process so much stimuli at a time. So if we can get some of that stimulation onto something else, it'll kind of disregard the pain, and it really does help. Moving on to pharmacological measures. So now we're talking about medication. So we have non-opioid analgesics. Again, we want to go from least to greatest. So we want to go with things that are not too intense for pain yet. So we have non-opioid analgesics like NSAIDs and acetaminophen. So NSAIDs include aspirin, ibuprofen, and a few other medications. So NSAIDs pretty much act in the tissues by interfering with the production of prostaglandins. And we're not going to get too into details about prostaglandins. You will learn more about that in Med-Surg. Acetaminophen, also known as Tylenol, doesn't really have much of an anti-inflammatory effect like the NSAIDs does, but it is pretty good at lowering fever, and it also helps with pain. Then we have adjuvant analgesics. So these type of medications reduce the amount of the opioid the patient requires. So for example, if the patient has to have an opioid, which is a narcotic, if they combine it with an adjuvant analgesic, an adjuvant drug, then maybe they won't need as much of the opioid. So these medications include anticonvulsants, antidepressants, muscle relaxants, corticosteroids. Those are just some examples. And those opioids are natural and synthetic compounds that we give to relieve pain, and they vary in potency, so some are stronger than others. And then we have controlled analgesia pumps. So that's what you see in the picture here. The patient has like an IV of medication. It can be morphine, it can be Dilaudid, and they have a little button here that they can push that has a measured dose of medication set at a specific interval that they can push it. So what's important here is that only the patient is allowed to push that button, meaning that the family member at the bedside, the friend, cannot push that button. Neither should the nurse. So if you have a patient, this is how they should be educated. Only they can push that button. And one thing to remember about this is that this is a locked box, so nobody should be touching the settings on this IV pump. And the medication needs to be verified by 2 nurses because this is a controlled substance. And something else to remember, this is an ordered medication. So the provider will write, how much medication the patient is supposed to receive and how frequent the patient is able to receive it. So just because the doctor ordered it that way and the patient is pushing it as ordered does not mean that the patient cannot experience those side effects. So you still need to continue to assess your patient because they can still receive too much medication, and that's not because there's an error, but because maybe their body just can't handle it. So just because it's set up that way and it's doctor's ordered, you still have to make sure that you're keeping an eye on your patient because you don't want that patient to become unconscious. So some tips for pain management. This is our last slide. Always continue to monitor effectiveness of pain management, whether you're using pain medication or non-pharmacological methods to treat it. We don't want the patient to be in pain. We want to make sure what we're doing is working. That relates to our nursing process. That's the evaluation. Is our goal working? Patient has pain, that's the problem. Our goal is to decrease the pain. We gave them pain medication and we told them to use distraction. Now we want to see if it's working. If it's not working, then we need to do something different because we don't want the patient to be in pain. You want to choose a pain scale appropriate for your patient. It doesn't matter if your patient can't tell you they're in pain, if they're nonverbal, if they're unconscious, if they're comatose. We are going to do a pain assessment on them. Remember that pain is subjective, so whatever the patient says, that's what we're going to document. We want to make sure that we take in consideration their past experiences, their cultural differences, anything that might influence the way that they're telling us what their pain level is. If we suspect that they're not being 100% truthful with us, then we want to, build a good rapport with them, gain their trust, and hopefully that will allow them to be honest with us that they indeed are in pain and we need to treat them. We do want to educate patients on non-pharmacological options for pain management, especially when the patient has chronic pain. So if the pain is chronic, that means the patient's going to go home in pain and they're going to have to manage this at home. Taking medication, yes, may be an option, but there are lots of other things that the patients can do that doesn't involve taking a pill. So we want to educate them on those. You as a nurse, you need to know your side effects. When you're giving a patient an opioid, or a narcotic, there's going to be side effects. Usually what we like to talk about most is respiratory depression, such as with morphine, that can cause your respiration to go down. So know your side effects of medications. Now again, this class, we're not emphasizing that. This is just for your knowledge. If you ever give any patient a medication, pain, or for anything else, you need to know what possibly can happen to that patient. You want to be careful with the elderly. So part of our natural aging process, our organs don't really work as optimal as they once did when we were younger. So remember, those pain medications or any medications need to be metabolized by an organ. And if that organ isn't the greatest, maybe it's not going to get metabolized as well. And it might just kind of stay floating around in the bloodstream. And those medications can build up over time and they might be more sensitive to those. So we want to make sure that we are careful with the elderly. Know that every patient is different and every situation is unique. So you may have a very young person who comes in, appears not to be in any pain, but they're in 10 out of 10 pain. Maybe they have sickle cell disease. That is this condition causes severe pain to young people, so we cannot judge. Maybe you have another patient that comes in who is addicted to opioids and they're asking for pain medication. They could truly be in pain, physical pain that they're feeling. You still have to do an assessment and you still have to treat them accordingly. Maybe there's a different kind of medication that can treat the pain. Maybe they need to be referred to a pain specialist, but you want to keep your biases out of it and treat each patient as an individual. And then we have delegating pain management. So all of those non-pharmacological approaches, a lot of them we can delegate. So repositioning the patient so they feel better, hot and cold pack, stuff like that, putting pillows underneath limbs, elevating limbs, turning on the TV, opening the window, stuff like that. You can delegate those things. And that concludes this module.